In lower limb, we have two different plexus, the lumbar plexus and the sacral plexus. And we have a gamut of blocks like femoral, obturator, lateral femoral cutaneous, fascia iliaca with a suprainguinal approach, ping block. We have a procedure specific only motor sparing blocks like adductor canal, dual subsartorial IPAC, genicular, poplitosciatic, caps block, and ankle block. So it is practically difficult to explain and go into the depth of each and every one, but I'll try to cover up the major blocks which we can do in our practice. And since, as I mentioned, there are two plexes, there are multiple approaches to different nerves, we need to choose an ideal block depending upon the type of surgery, and we need to definitely have a motor sparing effect because the patient mobilization is of utmost importance. So we'll be discussing the anatomy, indications, ergonomics, ultrasound images, and the videos. There will be a lot of videos, complications, and the tips to perform each and every block. So let us start with the anatomy of the lumbosacral plexus. All of us know that lumbosacral plexus starts from the T12 and ends up to S5. We'll be covering the lumbar plexus and sacral plexus individually. And there are the four main nerves of the lower limb which we need to block. Like if we need a complete block, like the femoral nerve, lateral femoral cutaneous, obturator, and the sciatic nerves. So, as I mentioned, lumbar plexus, it is from the anterior primary rami of L1, L2, L3 with greater part of L4 and variable contribution like from T12 or from L5 nerve roots. And the nerves from the lumbar plexus are the ilioinguinal, iliohypogastric nerve, the genitofemoral nerve, lateral femoral cutaneous nerve, the femoral nerve, which is the largest nerve, accessory obturator, and the obturator nerve, and the component to the lumbosacral front. So after coming out of the intervertebral foramen, each nerve then divides into the ventral and the dorsal ramus. The ventral ramus at the lumbosacral level runs in the lumbar paravertebral space and then it dips into the psoas major muscles. The psoas has two bellies, the anterior and the posterior. So as we can see here, the anterior belly is cut and the lumbar plexus lies in the content of the psoas major. Now, this is a lateral cut section. As I mentioned, this is the anterior belly, which is muscular and thick, and this is the posterior belly. Both are cut, and we can see the nerve roots coming out. So, after coming out of the intervertebral foramen, it dips caudally. Thereby, suppose if we are doing a cut section at the L4 vertebral body, the nerve root which could be there at this level, it could be from the L3, the nerve root which is the above. And as we can see from this cut section, it's a very highly vascular region. So it is one of the most deeper blocks. And as we can see, the branches from the lumbar artery and the deeper branches, the whole of the psoas major muscle is also very much vascular. This is a picture showing the arrangement of the lateral femoral cutaneous and the obturator nerve in the lumbar plexus in the psoas compartment. So as we can see, the obturator nerve is not almost present throughout. There could be multiple variations. It could be totally in a different compartment. This is of importance because while doing the ultrasound plus PNS lumbar plexus, or a PNS guided block, the motor response which we see is usually for the femoral nerve block. And this is the picture showing the sensory and motor distribution of the lumbar plexus block. As we know, it covers almost the anterior and thigh, almost up to the great toe. This is the myotomal distribution and this is the osteotomal distribution. So for performing ultrasound-guided lumbar plexus, it is recommended that use a PNS along with it so as to improve the safety. And definitely there are landmark approaches to it. So the standard block preparation, this is needed for all the blocks which I'll be describing, like IV access, the normal routine monitoring, the ECG, blood pressure, saturation, availability of intralipid in the OT, informed consent. You need to check for the correct site and appropriate sedation if any. So for lumbar plexus, we need a low frequency linear transducer since it's a deeper structure, usually a 10 centimeter needle. We tend to use a echogenic nerve block needle with a peripheral nerve stimulator and an injection pressure monitoring device if it is available. So usually if we want anesthesia, we will be giving a higher concentration, and if we are planning for analgesia, we'll be giving the lower concentration like 0.1 to 0.2% of ropivacaine and 0.25% of bupivacaine or levobupivacaine. So there are two techniques which has been described in the literature, like the Shamrock approach and the Trident sign, which I'll be describing currently. So ergonomics, usually the lumbar plexus, we need to put the patient in the lateral position the site to be blocked, it should be above. And as we can see, the person performing the block, the patient, and the machine has to be in the straight line always, because ergonomics are of very much importance. So now coming to the first view, like the Shamrock sign, which has been described. So as we keep our ultrasound probe, this is the iliac crest. That side on the cranial side is the subcostal margin. So if the ultrasound probe is kept just cranial to the iliac crest, usually will be at the level of L3 or L4 vertebral body. And as we can see in this picture, this is the posterior edge, this is the anterior end, and this is a classical picture which has been described, the Shamrock sign or the trifoliate leaf structure. So the muscle on the posterior is the erectus spinae, this is the quadratus lumborum, and this is the fleshy muscular psoas major, along with the pulsations of the lumbar artery. And this hyperechoic shining structure is the lumbar plexus. So this has also been described as a thumbs up sign, in which the knuckles correspond to the lumbar vertebral body, the thumb corresponds to the transverse process of the vertebrae, and so on. So the needle usually comes from the posterior end, and we tend to deposit around 20 to 25 ml of the local anesthetic. Along with that, we definitely like to see the quadriceps contraction. This is a video showing the scanning, and as I mentioned, the needle is coming from the posterior edge. So if we target the needle towards the transverse process, we tend to encounter the transverse process while reaching the psoas major. So in this video, as we can see, I'm just moving my transducer cranial and caudal so that the transverse process goes out of picture. And the needle comes from posterior to the anterior side, and we tend to deposit the local anesthetic. This is the another approach which has been described, like how we scan for the lumbar spine. So this is the parasagittal approach at the level of transverse process. This sign has been described as a trident sign. The muscle above is the erectus spinae, this is the cranial end, and this is the caudal end. So usually the lumbar plexus lies more posteriorly, and in this image, as we can see, this hyperechoic structure is the lumbar plexus. The needle can come from posterior to anterior, and we can deposit the local anesthetic. So this is the scanning of the spine, which we can see in the parasagittal view. As we can see, again, this is the cranial end, this is the caudal end, and this is the lumbar plexus, which lies in the belly of the psoas major muscle. As I mentioned, it's a deeper block, so we are bound to face complications. There could be inadvertent intravenous injection. Always keep a watch for last. You need to inject slowly and steadily. Wait after giving 4 to 5 ml of local anesthetic. Look for the spread of the local anesthetic. And if usually the needle visibility is one of the most important factor, which is technically difficult. So we need to go slowly, regularly. If it is not visible, we need to hydrodissect and identify the tip of needle, since there are visceral organs which could be damaged if a needle goes more anterior, and there is definitely a risk of bleeding or hematoma.